Hey everyone, my name is Ambry and I'm here to present to you on my case study on sickle cell disease today. So sickle cell disease, just a brief background, it affects millions of people worldwide, but it is most common in people from Africa, Mediterranean countries such as Greece, Turkey, and Italy, the Arabian Peninsula, India, and Spanish-speaking regions in South America, Central America, and parts of the Caribbean. So for the pathophysiology, it is a group of disorders that affect the hemoglobin, which is the protein in the red blood cells that helps carry oxygen throughout the body. The affected hemoglobin gene is called hemoglobin S in people with sickle cell disease, and this is where valine replaces the glutamate in the hemoglobin S strand. This causes the red blood cells to become more gel-like, sticky, stiff, and sickle-shaped, as you can see in this picture. So this causes the red blood cells to get more prone to getting stuck together and causing blood clots, and this leads to a lot of the cells actually being destroyed. So sickle cells live for only about 10 to 20 days, whereas normal red blood cells can live up to 120 days. So they have a shorter cell lifespan, which leads to an overall lower population of red blood cells in the blood vessels, and that's going to lead to the anemia. So etiology, sickle cell disease, the easiest way to say it is that it's an autosomal recessive disorder, meaning that if both of your parents have the trait, you have a 25% chance of being normal, healthy, no trait, no sickle cell disease. You have a 50% chance of inheriting the trait, and then you have a 25% chance of inheriting actual sickle cell disease, as in you get the hemoglobin S from both or the affected hemoglobin from both parents. So that would be the homozygous form is the sickle cell disease, and that's when you're going to have the most issues and probably going to die within 2 to 3 decades of life. The trait was thought to have come about from malaria because it is more common in those malaria-prone regions of the world. And also it has been found that people with sickle cell trait have about a 60% chance of not getting as sick and not dying as easily. They're protected about 60%. However, if you have sickle cell disease and then you also get malaria, they're going to worsen the effects of each other and increase your risk of illness and death. So there's different types of sickle cell disease. The one that we are going to talk the most about is that hemoglobin SS, which is sickle cell anemia. It's the most common and the most severe form. The SC is a milder form, and then we've got the two types of beta thalassemia. So we've got the zero beta thalassemia and the beta positive thalassemia. So the beta thalassemia is going to be the beta zero thalassemia is going to be the more severe form, and then the beta positive thalassemia is going to be a milder form. And then those SD, SE, and SO are going to be the rarer types. And then you've got the hemoglobin AS, which is just the trait, because the A gene is the normal gene that you would inherit. So it's the most common inherited blood disorder in the United States. There's about 1 in 500 African Americans that have it, and about 1 in 1,200 Hispanic Americans that have it. Total comes out to about 90,000 to 100,000 people in the United States with sickle cell anemia. And then about 3 million people have the sickle cell trait, and 10% of African Americans have the sickle cell trait. So African Americans in America are a lot more prone to having the trait. So the characteristic features of sickle cell disease are going to be anemia, periodic painful episodes, and repeated infections. Other common signs and symptoms are going to be jaundice, swelling in the hands and feet, vision problems, and delayed growth in children. And then other potential issues you might get with sickle cell disease would be stroke, leg ulcers, pulmonary hypertension, abdominal swelling, acute chest syndrome, dehydration, bone and organ damage, and multiple organ failure. And another one I didn't mention is going to be spleen issues. So a lot of people with sickle cell disease do not have a functioning spleen, or their spleen has been removed. And this is going to increase the risk of repeated infections even further. So going back to those painful episodes, those periodic painful episodes, we're going to call those painful crises. So basically, they're just occasional painful episodes that people with sickle cell disease get when they get those blood clots in their blood. It does typically occur in the chest, abdomen, joints, and bones, but it can occur anywhere in the body, and it can last up to several weeks at a time and can vary in intensity. And here's just a quick overview of the affected labs if you want to pause on this for a second, but I don't really have time to go over it, but I will go over my case study patients' labs in just a little bit. So the only documented cure for sickle cell disease is to get a blood and a bone marrow transplant. There are a lot of limitations to this. It's very expensive. It's very hard to find a good donor, and it's not typically done in adults. It's usually only done in children. Other treatment options, so the most common treatment options, are going to be to get blood transfusions periodically, and that's to supply the body with more healthy red blood cells, and also hydroxyurea, which is usually a form of treatment in cancer, but in sickle cell disease, it can actually reduce the occurrence of infections, malaria, blood clotting, pain, transfusions, and even death. And then also, they're often given pain medications, especially in the hospital when they come in with those pain crises. Gene therapy is something that's on the horizon. There's been a couple successful case studies, but really not enough research to start using it in practice yet. Penicillin is often given because it reduces the chance of infections, and is typically given to children less than 5, adults with the sickle cell anemia or the beta zero thalassemia type, or those people who have had a splenectomy or previous pneumococcal infection. So where we come in, medical nutrition therapy, currently there's no specific recommendations for sickle cell anemia. However, we do know that they need increased protein because they need more protein to be able to make more red blood cells. They also need increased energy because they have an increased resting energy expenditure due to their heart having to pump harder to maintain the blood flow and the oxygen throughout the body because of those decreased numbers of red blood cells. And the CDC says that people with sickle cell anemia can need anywhere from 1 to 3 times that of a healthy individual. So if you need 2,000 calories, they could need up to 6,000 calories. And that would be a lot more helpful to know if you had access to indirect calorimetry or something like that. We also know that they need decreased saturated fatty acids because they do have altered fatty acid metabolism due to the lack of blood flow in certain areas of the intestines where the fatty acids are absorbed. They do need increased omega-3 fatty acids and glutamine, however, because those are going to help improve the blood flow throughout the body. They could potentially need additional fluids. For one, it could be helpful in managing the sickling in the body. And for two, a lot of people with sickle cell disease have a lot of renal issues in that they excrete too much urine. So you would want to continuously replace that. You would want to monitor for micronutrient deficiencies for sure. Iron may actually need to decrease when the patients get repeated blood transfusions. They actually could get too much iron and then need to decrease their iron intake. So the most common micronutrient deficiencies, however, are going to be calcium, iron, thiamine, and vitamin C in this population. So we would also want to monitor for side effects of pain medications such as nausea, vomiting, diarrhea, and constipation. You would want to help out their food in any way you can. For instance, if they have nausea, you might want to give them smaller, more frequent meals, colder meals such as sandwiches instead of a big pasta dish or something like that that might make them nauseated with the smell and all of that. You would want to replace their fluids and electrolytes if they have loss of body water such as vomiting or diarrhea. They want to adjust the fiber, different things like that, and you would definitely want to monitor these side effects in accordance with their intake. So if they have decreased intake from this, you might want to see if a supplement might help them get their calories and their protein in. So on to my patient. Her initials are TP. She's a 29-year-old female, African-American. She was admitted due to a sickle cell pain crisis. Her past medical history, sickle cell anemia, blood transfusions, and anemia. She has had a few body parts removed, such as her spleen, like I mentioned earlier, and also her appendix, and a couple more organs that she was having issues with due to the blood clotting and cell death. She has had previous dietary education. She is what we would call a frequent flyer at the hospital. She comes in pretty often with those sickle cell pain crises. And when she came in this time, her doctor prescribed her a high protein, high calorie diet with 3,000 calories. So she does have some cancer and some diabetes in her family history. No sickle cell anemia in there, so it sounds like she just kind of inherited both traits from her parents. Social history, she's not married, she has no children, she doesn't smoke, she doesn't drink, and she doesn't do drugs, according to what we know. She is 5'4" tall, 155 pounds. She has a BMI of 26.61, which is slightly overweight, and she's 129% of her ideal body weight. What she usually eats at home, she usually has fruit, eggs, cereal, and or bacon for breakfast, sandwich, pickles, and chips for lunch, and for dinner, tacos or some sort of dish with pasta, bread, and vegetables. And then she said she always has 2 Little Debbie oatmeal pies for snacks every day. The brief overview of my assessments with her, I saw her 3 times. So the first time was the second day she was in the hospital. At that point, according to the electronic medical record, she had not eaten anything. So I went up there and I saw her. She confirmed that she had not eaten anything. She's been there. So I did ask her if she wanted any supplements. She said she doesn't like supplements, and I had actually already seen that from the record, but I just wanted to make sure. I did ask her if she would try maybe a nutritional shake, which is kind of like a protein shake that comes on her tray, and it comes in a little milk carton looking thing, and they call them Mighty Shakes. So she said she would try that. I ordered her 1 per day just to see if she likes it, and then I would have increased it if she did. I also ordered her a burger and fries because I asked her, what do you really want? What do you think you could eat? And she said she's really craving a burger and fries. So I ordered that for her for dinner and Computrition, which is the kind of the menu program for the hospital. I also offered to give her some creamy soups with her meals, or asked her if she wanted to be tallied, meaning that the nutrition text would ask her what she wants to eat for every meal, and she declined both of those, probably because she just didn't feel good enough to try creamy soups or feel well enough to be talking to somebody all the time about her meals. So I went to see her 2 days later and check up on her again, see if she had been eating any better, and she had not. She didn't try her burger or her fries or her nutritional shakes at all. So at this point, she's had no food in 4 to 5 days, except for she said she's had a little bit of apple juice that she's been sipping on, and that's it. So I encouraged her to eat. I said, you've got to start eating, or we might have to consider alternate means of nutrition. I might have to talk to the nutrition support team. You really need to start eating to get that protein in and start healing. So I told her I was going to see her the very next day, and I did. The same documented intake was on file. This is day 5 at this point. She said that she did eat a good dinner the night before, actually, that her mom brought her. So I was really happy for her. She did sleep through breakfast, but she said that she was ready to eat lunch whenever it came. She said she was feeling much better overall, and she was discharged later that day. So throughout her stay, she didn't have any trouble chewing or swallowing, nausea, vomiting, diarrhea, constipation. No edema, no wounds. The only thing that was really affecting her nutritional-wise was that severe pain that she was having. So, brief overview of her current medication. She was on 2 antibiotics. She was on hydroxyurea, which I mentioned earlier, but I do want to mention that that is given to this population because it raises the level of fetal hemoglobin in the body, which reduces the polymerization of the hemoglobin S and decreases complications and pain. She was also on 2 pain relievers, Benadryl and Dilaudid. She was on a blood thinner. Folic acid, Fulvite, she was on at home before she came here, and they just kept her on that. I'm assuming she might have had some issues in the past, or some doctor told her to take it, because it is known that it possibly helps make new red blood cells in the body. So her folic acid was fine upon this stay, but they just kept her on it just because that's kind of just some vitamin she takes on a daily basis. And they were also giving her IV fluids. So a brief overview of her lab values. It does look like she has a little overhydration going on, probably because of all those IV fluids they're putting in her to try to help with that sickling in the body. She probably has some kidney issues going on. It does look like she's probably got some proteinuria. She's excreting too much urine, and protein's kind of going out with it. Probably has some bacterial infections and inflammation going on, that normochromic, normocytic anemia, definitely, and some red blood cell breakdown. So all of this is kind of expected with this population. So her estimated needs, what I calculated, was 1,868 to 2,023 calories with a 1.1 stress factor, but I would say this is probably the minimum. We don't know exactly how much she needs because we didn't get any sort of indirect calorimetry on her. So based on the fact that she could have up to 3 times what she needed, I did just keep what the doctor had prescribed on file, the 3,000 calories per day. I figured it wasn't going to hurt anything, and I didn't want to underfeed her for sure. Her protein, we calculated 1.5 to 2 grams per kilogram, which is 105 to 141 grams per day. So for her nutrition diagnosis, her PES statement, I just said inadequate oral intake related to pain and increased needs from the sickle cell anemia, as evidenced by documented intake on file, 0%, and the patient just telling me that she had not ate hardly anything over 5 days. So I didn't classify her with malnutrition because her weight was stable over time. As of admission, I did not get a weight towards the end of admission, however, but when she got here, her weight was stable from last time she had been here over several months. There wasn't any new weight on file, like I said, and I didn't see any signs of subcutaneous fat loss or muscle wasting on her. So overview of all the interventions I did with her. I already mentioned the creamy soups. I offered those to her. She declined. I offered her those alternative meal choices. I did give her that burger and fries, but she also declined. Ordered her the vanilla nutritional shakes, which she did not try. We did recommend her a multivitamins that she was not eating just to get some vitamins and minerals in her and reduce the chance of deficiencies. We also recommended her a probiotic because she was on some antibiotics. We recommended reweighing her, and we would have sent her to the nutrition support team had she continued to not eat. So last slide, I just want to talk about the monitoring and evaluation real quick for her. So I wanted to monitor her weight status, the intake that she was having of macronutrients and micronutrients, specifically protein and calories, and I was watching her macronutrient labs as well. And so for her 3 goals for evaluation, I said that she would not have any significant weight loss upon discharge, that she would hopefully start eating at least 2/3 of her meals prior to discharge, and that her macronutrient labs would be within the normal limits before she left. And here are all my references. And if y'all have any questions, you're welcome to email me with those. Thank y'all for listening.